slide is an individual patient meta-analysis of 5 randomized trials, which confirms the benefit of CRT with or without a defibrillator in patients with HFrEF. In this meta-analysis, nearly 4,000 patients were studied or included in the analysis, and you'll see that there was a 34% reduction in all-cause mortality. And when one looks at the hazard ratio for total mortality across the spectrum of QRS durations, you'll see that patients benefit to QRS durations as low as 120 milliseconds. The ADAPT response trial, one of our most recent and largest trials of CRT in heart failure patients, confirms the benefits of cardiac resynchronization therapy. So on top of all of those prior trials, on top of the meta-analyses, this more contemporary study demonstrates a reduction in the incidence of all-cause death or interventions for decompensated heart failure. And while there wasn't demonstrated statistically significant superiority of this newer approach to delivering CRT, the trial clearly demonstrates clinical outcomes that are comparable to prior CRT trials. CRT is also associated with clinically meaningful and significant improvements in quality of life. This slide summarizes many of the landmark trials of cardiac resynchronization therapy and puts into context the reduction seen in, the improvement seen in quality of life. Here, the quality of life instrument used was the Minnesota Living with Heart Failure score. A lower number implies an improved or better quality of life. And you'll see in the overall pooled analysis of these studies, there's about a 7 or 8 point reduction improvement in the quality of life score. You'll see the data for the individual studies, but to put this finding into context, the minimally important clinical difference accepted for the improvement in this quality of life score is 5 points. You can also compare this to the quality of life improvements seen in trials of guideline-directed drug therapies for heart failure, which average about 2 or 3 points. So this is a very large improvement in quality of life for our heart failure patients. An individual patient data network meta-analysis attempted to indicate which patients benefited most from CRT-D and CRT-P. And you can see that there are certain criteria that favor a better improvement, particularly calling out left bundle branch block. But interestingly, it's important to note that women tend to improve more than men, and we'll come back to that in just a moment. So in this patient level meta-analysis of 7 CRT trials, there was a greater reduction in heart failure hospitalizations or death in women, irrespective of body size. The effect of CRT on heart failure hospitalizations or death was observed at a shorter QRS duration for women, that is 126 milliseconds, than for men, 145 milliseconds. And the reduction in heart failure hospitalizations or death was greater for women than for men. So women, particularly those with non-ischemic cardiomyopathy, represent ideal candidates for cardiac resynchronization therapy. And in this trial, we also demonstrated that the effects were preserved regardless of etiology of heart failure, that is ischemic or non-ischemic cardiomyopathy. So while the reverse remodeling effects of CRT are a bit greater in non-ischemic versus ischemic cardiomyopathy, the effects of CRT on clinical outcomes are the same regardless of etiology. Now let's talk about the guidelines very briefly. There is broad agreement on eligibility criteria for CRT in patients with heart failure. For time's sake, let me just highlight that CRT is indicated for symptomatic heart failure patients with reduced ejection fractions on optimal medical therapy with a QRS duration greater than 150 milliseconds, or a QRS duration between 120 and 149 milliseconds, particularly with a left bundle branch block. You can see the recent guidelines from the ACC, AHA, ASE, et cetera, that describe the appropriateness of CRT in various patient groups. And the indications for CRT are really quite broad across the spectrum of QRS durations from 120 milliseconds to greater than 150 milliseconds. So let me get to my final couple of slides as time is running short. First of all, heart failure is managed today by a comprehensive management team, a multidisciplinary team, and CRT remains a cornerstone of comprehensive heart failure care that should be considered in all eligible patients. Thank you.
Practice. And before I start, I would like you to think for a second what for you would be the #1 reason for non-response to CRT. Just think about it for a second. I think it depends on where you're coming from. If you are from the imaging side, you might think, non-response, there is not a lot of desynchrony. Other people might think, patients still end up with heart failure. Other people say, if I do a CRT implantation, patients don't feel better. But you know what I think, and what I'm pretty sure is the number one reason, it's a no implant. And I'm going to talk about that. We fail to achieve appropriate implantation rates for this fantastic life-saving therapy. When you look, for example, at the last 3 large trials done in HFrEF with medical therapy, so Paradigm, DAPA, and Emperor, you see first of all that the event rate, even in the intervention group, is up to 20% at 2 years. That means that 1 out of 5 of these patients, if they were even on ARNI or an SGLT2, ended up in the hospital with heart failure or were dead. Now, when you look at the implantation rates of ICDs and CRTs in this group of patients, you see they're pretty low. ICD was 30% and CRT was 12% in a patient population with HFrEF. So almost all of them should have been implanted with an ICD, and about 1/3 of them should have gotten resynchronization therapy. So even in the trials, we're not achieving a high implantation rates of Class 1 recommended therapies. When you look at real-life data from ESC-HF long-term registries, you see that only 1/4 of the patients who should have gotten a CRT actually were implanted. It was a little bit better in another registry where you see it went up to 47%, but overall, only 1 out of 3 of the patients who has a wide QRS and HFrEF actually receives resynchronization therapy in Europe, and it's even less in the Far East. This is important because also delaying the decision to implant with resynchronization therapy portends a poor survival. These are data from our own center where we looked at the time period between the diagnosis of HFrEF and a wide QRS versus the implantation dates. And what you could see is if we waited longer, the chance was a lot higher that that patient would die or be hospitalized with heart failure. And it's the same from a large data set of more than 60,000 patients undergoing CRT implantation between 2010 and 2019 in England. What you could see was that the patients who experienced or who were implanted during their first hospitalization had actually the lowest mortality and the lowest rate of heart failure hospitalization. However, if they only got their implantation years after the diagnosis, the risk for adverse events was much, much higher. So living longer with HFrEF and a wide QRS is associated with worse prognosis. So you have to do something to actually amend or treat these patients earlier. That is why HFA, ERA, AICVI, and ESC came together and we wrote this document. It's not easy to bring all these associations together to find common ground, but all of us felt the need that we have to do something about the spore implantation rates. So this is a document which I highly recommend you to have a look at, because it's a call for action, for referral and optimization of care with regards to resynchronization therapy. We identified many barriers for referral for resynchronization therapy or ICD therapy. Why? Because patients are managed in primary care or by physicians who are unaware of the benefits of device therapy. There's also patient problems. Patients perceive devices to be different from drugs, and a lot of patients don't want to have a device in, especially if they don't know the benefits of the device. There are uncertainties about the procedures, there are guideline discrepancies, there is not a lot of cooperation between heart failure doctors and electrophysiologists, but all of these things are you can improve them. How can you improve this? Well, first of all, you can try to improve the identification of the patient. Put a tag on a heart failure patient. You know, this is a heart failure patient. This patient deserves special care. You have to look for the indication to send them for device therapy. You can look at the EKG, of course. We have set up a system in our own hospital where we look at all the EKGs been taken in the hospital. That's hundreds and hundreds of thousands of EKGs on a yearly basis, and there's an automatic screening mechanism installed where we actually detect patients with a wide QRS. Of course, education for primary care, education for heart failure doctors, for electrophysiologists, for geriatricians, but also for patients. So you have to engage in patient associations to improve the referral rate for these device therapy. Another myth that exists, because there are a lot of myths are untrue stories, is that medical therapy can actually prevent you from placing resynchronization therapy. Well, this is not really the case. Medical therapy works extremely well if you have a narrow QRS. You see on the left side panel that there is an ejection fraction improvement up to 10% in the narrow QRS. But this ejection fraction improvement is far less if you have a wide QRS. On the right side panel, you see a study done with ARNI, so with sacubitril valsartan, in narrow and wide QRS complexes patients. And you see that the improvement in ejection fraction was considerably less in patients with a wide QRS. There is a synergistic effect of devices and medical therapy. This is another study where the investigators looked at the benefit of combining device therapy with medical therapy. And you see, if you give more medical therapy, that you have better results if you combine that with device therapy. A very prevalent problem is the thinking about non-response. Non-response is not a binary yes or no. There is no patient who received resynchronization therapy because of a class 1 or 2A indication who did not have benefit from the device. And if we would be oncologists, we would say that we have a fantastic therapy because all the patients who were implanted had at least a partial remission of their disease. Of course, remission doesn't always mean that you feel better. Most patients with breast cancer, when they get their breast removed, they don't feel better. They feel worse, but they live longer. Well, the same is true for CRT. Yes, you get a device implanted, you might not feel better, but for sure, all the trials show that you will live longer. And in most of the cases, you will also feel better. I've never experienced a patient who went worse after the device implantation, of course, under the condition that the device was implanted because of a wide QRS. So where do we take this? Well, the next document that we wrote was how can we now integrate device therapy in patients with heart failure? And we suggest that you move away from the classical sequential model where you actually have heart failure and then you go for a device to a more integrated model. What do I mean with that? Well, you integrate the diagnosis with the therapy. And the therapy is not only medical therapy, but it's also device therapy. So if I'm faced with a patient with heart failure with a wide QRS, yes, for sure, I start with medical therapy. But I already think about the device. And when I think about the device, then I will also tell to my patient, you know, we also have a device here, and if medical therapy doesn't kick in pretty soon, we're going to think about this device and we're going to offer you this device. So we plant the seed in the head of the patient that he or she might also need a device. And that makes my life a lot easier because after a couple of weeks, if I see that patient back, I talk again about the device. It's not something new because then the patient will tell me, yeah, you talked about this, doctor. So what is this device? How can this help me? And then we are on a good pathway, and then we can implement this class 1 life-saving therapy much sooner. Also bear in mind that in the latest ERA guidelines, we wrote a sentence that it's absolutely okay to consider resynchronization therapy early on. You don't have to wait for 3 to 6 months. If you're faced with a patient with a wide QRS, large ventricle, you start medical therapy, you do an early evaluation, and then you already offer resynchronization therapy. How do you do the follow-up? Well, we also suggest you do a structured follow-up, not with difficult tools. These are very easy to adopt tools. You take an EKG to make sure there's BiV pacing. You do a device analysis to make sure the device is appropriately programmed and to make sure you have 100% BiV pacing. You do a chest X-ray to make sure there are no comorbid conditions and to make sure the lead is in the right position. And then you try to optimize things. You optimize the device settings. You also optimize medical therapy because now the wide QRS is gone. So now medical therapy will kick in. And now you have more room for medical therapy because the blood pressure is a little bit higher and therefore you can increase the dose of RNA or ACE or MRAs or beta blockers. Beta blockers, you can easily give them after resynchronization therapy because the problem of bradycardia has disappeared. It's also time now to treat comorbidities, iron deficiency, obesity, COPD. Treat all these comorbidities, and if you do that, if you take everything together, then you will reach a better outcome. Thank you for your attention, and I'm more than
and clinicians understand how heart failure and its management affect patients' lives, and also to obtain insights into patients' needs and perceptions with regard to the implantable cardiac devices. And finally, to involve patients in direct HF educational program. And the methods were as follows. We had a working group composed of patient representatives, heart rhythm specialists, heart failure cardiologists, and heart failure nurses who developed a 25-item questionnaire. And the setup was an online, anonymous, and the link dissemination went through patient advocates and patient organizations. And these were the representatives involved, 5 patient representatives from different geographies, 6 patient associations from Portugal, France, Canada, Europe, and the UK. This is information about those who responded to our survey. There were 326 respondents in 7 countries. 59% of those were from the United Kingdom and 36% from the United States. Overall, 34% were women. Of the respondents, 56% had an implanted cardiac device. Age-wise, 60% were in between 55 and 74 years of age. And importantly, 51% were involved in patient group or association. So now let's go to the heart failure symptoms and the results.
Cecilia, thank you so much. My name is Mark Bain. It's a pleasure to be on this direct heart failure group with so many amazing patient partners and advocates and healthcare professionals from across the globe. I'm going to tell you just a little bit about some of the results for treatment objectives and heart failure symptoms. Next slide, please. We asked our participants really to rank the 3 most important treatment objectives when it came to their care. One of the first ones was maximizing quality of life. Number 2 was increasing their life expectancy. And number 3, avoiding unnecessary hospital admissions when related to heart failure. So all pretty standard. What was really interesting was looking at maximizing quality of life over increasing life expectancy. It's that question that we always have, quality versus quantity. Look forward to the questions and hearing more from Stephen about that after. Next slide, please. And then we wanted to know a little bit more about the symptoms when it came to people's care and the impact that it had on their quality of life. And really, when we asked our patient partners in the survey what was reported to have the greatest impact, it was ongoing fatigue and lack of energy, followed by shortness of breath during exercise, and then anxiety and low mood. Number 3 surprises me because maybe it's possibly overlooked too often. We don't think about anxiety or overload when we think about the physical health. So those are some surprising symptoms. And Cecilia, I think, has a few questions for us.
Yes, Stephen, my question is to you. Are you surprised by these responses?
No, not really, Cecilia, because we, as an association, along with several others, conducted a survey and published a white paper on this subject. And that what came out of that was that patients are really more interested in improving their quality of life on a day-to-day basis rather than having longevity. The other thing which has been come to the forefront very recently is this need for psychological help dealing with anxiety and depression, which is related to heart failure and all chronic illnesses, to be fair. It's very, very much underestimated, as Mark has said.
So thank you for that. I mean, these responses have important messages for us, the physician scientists, and also for practicing clinicians asking the right questions.
Thanks, Mark, for the previous information. We're now going to look on further and look at current knowledge and satisfaction with information received both in as medication for heart failure and for implantable devices. Okay, so here in this slide, you can see that out of the total number of respondents, and we're talking about everybody who answered, they said that their knowledge of heart failure medications was either good or very good to 56%. Next slide, please. Yeah, if we move on to the knowledge about implantable cardiac devices, and again, we're dealing with the whole population of respondents. Here we have a similar result with 48%, just under half, who said they had good or very good information. Given out before the implantation of a device. And here we're focusing on the 181 respondents who were implanted. The vast majority, 82%, were fairly or very satisfied with the information they received prior to implantation. After implantation of a cardiac device, again, we have around about the same figure. This time it's 80% of people who were fairly or very satisfied with the information that they received after implantation.
So thank you very
much. What we usually do today in clinical practice. there are several different ways to answer that question. So one way to look at it is that there is sort of generic heart failure pathophysiology with neurohormonal, changes and with hemodynamic changes, and we use the common medications. But then there are some specific abnormalities that needs to be treated in its own. So for instance, if you have iron deficiency, you need to treat iron deficiency irrespective of the baseline medications or what people are on. So we can kind of think about CRT in a way that and dyssynergy, that is a sort of a specific abnormality. So wasting or waiting too long to give the therapy, the likelihood is that the heart failure will just continue to get worse. So that's sort of one way to look at it. And then the second thing is that, by the time you have wide QRS and low EF and you're sort of a candidate for CRT, it is likely